Hi, good morning, everyone. Thank you for taking the time out to join this early morning screening webinar. It's mainly aimed at front of house staff. So we'll just do a couple of introductions just while everyone's joining. So hi, I'm Wasim. I'm clinical lead for Birmingham, Solihull, Black Country, and Norfolk and Waveney, and also part of the professional development team delivering the educational talks to you guys. And I'm joined by my colleague Beck.
Hi everyone. Like Wasim, I'm also a clinical lead. I cover Greater Manchester, Cheshire, and Merseyside, and work with Wasim alongside delivering your CPD. Welcome.
Thank you. So a bit about primary eye care services. We're the largest single provider company who have essentially get contracts from the ICBs and then contract out to practices. We have services in 29 to 30 out of 42 ICBs across England with over 3,100 optical practices offering some form of enhanced service, CUES, MEX, post-cut, pre-cut, glaucoma services, etc. We are also a not-for-profit organization. Those who don't already follow us, do follow us on LinkedIn, especially because we do post quite regularly about the NHS 10-year plan, CPD, and other upcoming events. For the clinicians on the call, there is half a CPD point for today's talk because it's only 30 minutes long and it's for optoms and DOs. The certificates will be sent to you within about 7 working days. Do check your junk mail just to be on the safe side. But to all the colleagues on the call today, the recording will be shared with you as well, and it will also be put on our YouTube channel for everyone to watch at their convenience as well. Okay, just before we start, a few caveats for those who are based in and around Leeds or Yorkshire side. For the last 12 months or so, the whole process with Leeds changed, and all patients who need a CUES, they don't have screening done in practice. They all have to go to our central telemedicine hub, who then do the screening, and then they then distribute out the CUES to the practices. So it's a completely different system. So that's the one big caveat in Leeds. In Southwest London, when you hear us talk later about if you can't find an appointment in general, what do you need to do? And more in vast majority of the areas, practices are contractually required to physically call other practices to get the patients in. However, if you're based in Southwest London or you've got a GP, the patient's got a GP in that area, then practices are encouraged to help finding a patient, but it's not mandatory. Okay, so just a bit of background about CUES. So has been around since COVID times, so for the last 5.5 years, and it's for patients with acute eye-related symptoms. So it is symptom-based. So these are for patients who've got symptoms that are not appropriate for a sight test, but they can be referred to you via many streams, most commonly self-referral, also one-on-one GP, A&E, hospital eye services, etc. And the key thing here is that there's a collaboration of local optical practices working together for the benefit of the patient, and you'll hear us talk about that throughout the talk. Some of the common presentations, this is not an exhaustive list, but this is some of the common presentations that patients could present with that are eligible would be an acute recent onset red eye or painful eye, foreign body or corneal abrasion, sudden change in their vision, stroke central distortion, and flashes and floaters. By acute, it typically means within 1 month, but some symptoms are suitable if they're within the past 12 weeks, especially if they've had them for say 8 weeks, but the symptoms are worsening recently, then that would be suitable. So just a bit more elaboration on the type of symptoms. You got redness, swelling, pain or irritation, vision loss, double vision, distorted vision, and like with flashes and floaters, if they're between 8 to 12 weeks but they're worsening, then that is definitely suitable. And you just need to remember to advise the patient about dilation. Most areas will include all ages from 0 to over 100, but some areas do have an age limit. So do check with your local lead if you're not sure about your own area's protocols. So just a bit of some national data. So this is from May 24 to April 25. So in that 12-month period, we saw 370,000 patients nationally under CUES, and 77% of those patients were actually managed within community optometry, which is a massive, massive number. Okay, so only a relatively small number were referred onto the hospital, 14%, which is to be expected with an urgent eye care service, and 5% routinely as well. So that's a massive, massive big difference. And this kind of data here is what kind of solidifies and creates a really good foundation for CUES nationally that the commissioners love, and then we can then try to expand on it. So a big thank you and well done to everyone who does CUES, because it's because of your contribution in your own practices. This is what the evidence that we've got here to show how effective and how powerful CUES is to saving appointments at the hospitals and being cost effective to the NHS systems as well. So I'm going to focus on screening. So as we said before, it's symptom based, but the other thing you've got to work out is eligibility. Now, eligibility comes under two different branches. The GP surgery, so it's not where the patient lives, it's where the patient's GP surgery is. The patient could live in Birmingham, but they have a GP in Coventry, and in that case, Coventry isn't commissioned for CUES, so that patient won't be suitable. Also, are they symptomatic? Are the symptoms? Do the symptoms fit in with the CUES eligibility criteria? And then you would need to check the urgency. So the updated CUES module, it does support live triaging and screening. So we do advise you to, if a patient does make contact, that you add the patient onto Opera and you go through with them live on Opera. And that way you can also check whether the system lets you proceed, because you'll be able to check where the GP is based. Okay, so as you said, the triage screening process begins when the patient contacts you by telephone or via face-to-face. And there is a paper triage form that you can have to assist you. And for those who don't have it, do contact your local lead or contact us centrally, and we'll give you the email address at the end of the talk as well if you're not sure on that. How do you add a patient onto Opera? So at the top, you've got a general tab. You come down to manage patients, and then you click on the right hand side, the quick patient add, and you put in first name, surname, date of birth, gender. Also put in postcode. It helps you with the lookup. And if for some reason you can't find it, it might be that the patient's registration details at the GP, uh, their details might be slightly different. They might be registered under the maiden name, and now they're giving you the updated surname. So it's always worthwhile checking that. The other way you can do it is on the top here, you've got, I know the patient's NHS number. You can search the NHS number and date of birth. Now, how do you find the NHS number? The patient can Google it online on the NHS website, and they can get it texted to their phone. So it's really easy if they've got access to the internet in order to obtain it. That's the most accurate way to try and find it. So then you click find patient, and then you can then import it that way. Now, if when you're trying to import, the import button becomes grayed out and you see two green ticks, that means typically that patient has already had an episode added onto Opera already, i.e. they've already been imported. So how do you then import them again? On the left-hand side of the Manage Patient screen, you've got these three tabs here, NHS number, date of birth, surname. You can put in at least two of those fields, click search, and it will bring up those details. The important bit, well, like I was saying earlier, is that Opera will take the information that is from the NHS spine. So the NHS spine is a digital record that's of the patient that the patient's GP maintains. So again, if the patient has one surname at the GP but hasn't changed it and they've told you a different surname, you won't be able to find them. That's why searching the NHS number is the most accurate way. Now, sometimes when you you find the patient, you click on CUES and it says, a pop-up comes up saying this patient is not suitable because they've got a GP in Brighton. And you're thinking, actually, the patient's always been registered with a GP in Manchester. They've always lived in Manchester all their life. To us, Brighton means by default that there's a problem with the registration on the NHS spine. So as soon as we see it, we know. So when we get these queries in, we advise you that for the patient to contact the GP and get their details updated on the NHS spine. It's not something we can do. It's only the GP can do it. And once that's been updated, then it can take up to 2 weeks for the system to refresh and for those updated details to reflect on the NHS systems. It's nothing to do with Opera. It's all to do with the NHS systems. So the way that you can try to refresh the details on Opera is that when you bring up a patient record on the left-hand side, you see a blue arrow. You click that and that will update the details. Now, if you need to see this patient urgently, but you can't add them on, what we advise you to do is see that patient. Obviously, if there's any referrals, do that outside of Opera. And then when those details are refreshed, you add them on retrospectively. And just make sure that you put you put the notes down in the comment section to explain why that delay has happened. It's not your fault. But if you put that down, then at least if there's any queries from the finance department, the ICB, or any time frame queries, we can look and we can understand actually, yes, this is something that was an extenuating circumstance. So just to reiterate here, the patient's symptoms are the key bits. So what we need to do is when the patient first makes contact, we need to understand, are those symptoms suitable for CUES? And then from then on, it's then, if they are, is the patient be booked in for telemedicine or for a face-to-face assessment? So this is the paper triage form. That is the generic one. Some areas do have customized ones because of the time frames and different suitabilities. So if you're not sure, do contact your local lead, and that information will be put up at the end of this talk as well, with all the contact details. So on your screening form, when you add the patient on, one of the first boxes that comes up is source of referral. Where did this patient come from to contact CUES? Were they referred via the GP? Did they just walk in themselves? Were they sent by 111? Were they sent by accident and emergency? It's always very helpful to us if you record that accurately, because when we then audit the data, we have a look, we can see actually X amount of these patients have come from GPs, X amount of these patients have come from pharmacies. And if anything needs to be improved, we can then use that as a quality improvement program. And the ICB will also want to know where these patients come from as well, because the goal is that they come from the GP reception team and not from the GPs directly, because again, that's wasting an appointment. So the goal is an ongoing communication with GP staff to say, you don't need to book these patients in with the GPs if they're suitable, you just refer them directly to the practices. And the bottom bit is about summary care record. So this is where you can obtain, or the clinician can obtain, information about the medications and allergies. So if that's something that is useful, you need to make sure you ask explicit consent from the patient to say, can we have access to this? Usually they're okay, but as long as the patient is made aware that the clinician can access this. Then we come on to the actual symptoms, and where you've got all these different symptoms here, and then you've got a flag at the top, and the flag has different colors, and that would be based on the urgency of the appointment. So I'll just show you quickly here. You've got 4 different flags. Green flag generally means it's slightly less urgent. Orange means urgent. Blue means maybe not suitable. And red flag would mean actually this is serious. Check with your clinician to see whether this patient needs to be seen very soon, or do they need a referral to ED. When you make it, when you've selected the appropriate options, the flag will come up, but you can click on the drop down and you could change the flag. Okay, so but most areas that operate CUES 2.0, the time frame is generally 24 hours. Any symptoms, the patient needs to be seen within 24 hours from clinical contact. And if you're in an area which doesn't operate that and you have a different system, then do check with your local lead. But you can toggle down the bar and change the management here. And then you've got your final outcome from screening. And these are the different outcomes. And the most common one would be see it face to face. So you are bypassing the telemedicine and you are seeing immediately see it face to face. And then you can make some additional comments here. This is always very helpful about the symptoms, flashes and floaters for the last 3 days, etc. And then once you've submitted this, then the clinician, the optometrist, will then pick this up, or it could be a CLO if it's an anterior eye symptom. They'll pick this up and then they will continue it. But from the front of house staff point of view, this is where the screening bit ends, and then you pass the care on to the clinician. A bit about symptoms. Red and or painful eye. They're eligible if their symptoms lasting more than 5 days and they're worsening, or they've had symptoms which have not resolved after 5 days, or they've been referred from a GP or pharmacy. They must be seen. Okay, so if the patient's gone to the pharmacy and then the pharmacy said, okay, you need to go to your optician for a CUES assessment, don't then bounce them around to somewhere else. Okay, in order to get the patient seen, then those patients are suitable. If the patient's presenting with a red eye for less than 5 days and they don't have any other symptoms, no pain, no light sensitivity, no vision change, check with the clinician, but more often than not, they are usually deflected to self-care. But we always advise you to make those relevant notes and check with the clinician for each kind of patient contact to make sure that the patients are being advised correctly. Contact lens wearers with symptoms suggestive of anterior eye or contact lens related problems, they should be directed to their usual contact lens provider first. Okay, and if they cannot attend that practice because they're closed, etc., then they can be seen at your practice for CUES, as long as you just make the relevant notes on your records to explain why. Flashes and floaters, as we know, you need to advise the patient about dilation. If they have flashes and floaters with a curtain or veil, then that's a red flag and you need to contact your clinician just to see whether that patient needs to be seen ASAP right now just to be assessed, because that patient is a higher risk of a retinal detachment, or if you can't, then does the patient need a referral to emergency department? And we've talked about the timescales about flashes and floaters getting worse, etc., earlier in the call. Sudden vision loss and or distortion. So this is where you have to think, if it's within the last month, generally they'd be suitable. If it's been over 1 month and the symptoms haven't been getting worse, then check with your clinician because that might need a side test instead. But those patients with central vision loss and or distortion, they will be suitable for the OCT pathway, where if you have an OCT, you can then do a face-to-face form and you can add on a separate OCT form and claim an additional fee for that. But that is only for patients who complain of vision loss. So someone with flashes and floaters, for example, with no vision loss, they are not suitable for the OCT pathway. But we do elaborate more on this on our clinical webinars, and they will be on the 1st of December. So this is just to be a reiteration about the different kind of questions that you can ask for different kind of presentations. But then these slides will be shared with you afterwards as well. So we talked about this earlier. If your CUES practice cannot see a patient within the time frame, 24 hours, then it is their contractual responsibility to get that patient booked in elsewhere. So you would call other local practices to try and get that patient seen. Now, some areas which do have a telemedicine service commissioned, you can refer that patient to the telemedicine line, give the patient the phone number, and they can call. But in all other cases, then it's the practice's responsibility, with the exception of Southwest Londoners. Okay, so you've got clinical leads, Sana and Ian, that you can speak to about that. Now, what if, we always get asked, what if you can't, we call around other practices and we can't get that patient seen? Then that needs to go back to the clinician for advice. Can that patient be seen the day after and the time frame slightly extended? Or does the patient, or are the patient's symptoms so urgent that actually he needs to be seen today? And if we can't get the patient seen today by an optical practice, that patient needs a referral to ED. So always just check with the clinician just to get that fail safe. For non-participating practices, if you've got practices around you, or those on the call today who don't participate, then on our website, we have a find a practice tool where the patient or you can put in the patient's postcode and you'll bring up a list of optical practices that are accredited in locality to the patient with the contact details. Okay, but it's always worthwhile advising these practices to say, actually, you can't say to the patient that it's a walk-in appointment. Okay, an appointment needs to be made for this. So there is a specific time scale, but the practices must not say to the patient, oh yeah, if you go in now, they'll see you within 10 minutes. That's not going to be the case in a lot of practices. There are CUES leaflets and posters available about this, and they are available on our help page as well. And Beck, if you could just put the link in for everyone on the chat box, please. So the screening outcomes are generally going to be see in practice face to face, telemedicine or see in practice either telemedicine or face to face, or if you don't have capacity, refer to another CUES practice. And we always advise that if you contact Practice B down the road and they can accept your CUES patient, you add on the screening form and you click refer to another practice. It will then come up with a red tab. You then have to click that red tab, select the practice that you're referring it to, send it, and that episode will be transferred to the other practice who can pick up that episode of care. The other outcomes would be not suitable for CUES or emergency referral to the hospital. CUES and site tests. So again, CUES is symptom based, and during the initial consultation, you'll be able to make a decision whether that patient, if it was from a site test the patient's booked in for, from the history and symptoms, if it's bypassed your initial triage, you should be able to make a decision from then whether that patient has symptoms that are suitable for CUES. And if they are, then you stop the site test, book in for CUES, and then you would do the site test on a different day. There are only very small, or only a very small number of circumstances where the patient can be seen on the same day for both the CUES and a site test, which is where the patient's VAs are visual acuities are unsafe for driving and they need to have glasses made ASAP, or they have mobility issues so they can't keep coming back in. And if that's the case, then just make the regular notes on the records. Do not add, if you've seen a patient for CUES that's from another practice, do not add them onto your practice reminder system for routine eye exams unless they specifically ask for it, because the sight test would be at their normal opticians. There is further information from this on a CUES document that's on our help pages, but you cannot, just to reiterate, you cannot do a sight test and then refer them into CUES. You need to do a CUES first. These are some of the examples of red flags in terms of these are where you need to get clinical advice from your clinician. Flashes and floaters with a curtain or veil. They've had an injury, foreign body or chemical injury. Sudden painless vision loss, which is acute. A sudden painful eye. Those with double vision and trauma. These symptoms are not suitable, generally headaches. They are more going to be suitable for sight tests. And I know sometimes GPs refer patients in for CUES where they have headaches, and that's just a case of letting the clinical leads know so we can educate the GPs. Unwell patients who have got symptoms such as TIA or stroke, those patients need to be referred immediately to the stroke clinic for further investigation. Contact lens practice with a contact lens patients with anterior eye symptoms like we discussed before, or those patients with long-standing symptoms of had gritty eye for the past year, it hasn't changed. Those patients are not suitable. So some tips from diary management would be like to pre-allocate CUES slots, and these are just recommendations. If you have multiple clinics, stagger them so you have different times of day. Review and adjust depending on demand as well. And we always advise you to kind of put in clear and concise notes in the diary to say that these are cues and these are the symptoms so that they can be picked up quite easily. For those who have really good diary management and it's working really well, please do share some information in the Q&A box just about your top tips so that we can share this with other practices. The key thing here is that we are all working together for the benefit of the patient. The patient is central. The clinicians have a key role in triaging. That's why we always recommend, especially at the start, if you're new to CUES, that all these CUES patients who make contact with the practice, that the staff check with the clinician to make sure that these patients are suitable and are seen within the time frame. This patient's had vision loss since this morning. Can we see them within 24 hours? The answer would be no. This patient needs to be seen ASAP, like within the next few hours, ideally. And that's a case of the clinician making that call. So some examples of how practices work well together. You can have details of the nearest 5 CUES practices to yourself, like blue tacked onto the wall with the contact details. You can buddy up with neighboring practices, have a WhatsApp group. You can check with your local optical committee to see whether there is one for there that you can put in any notes, like has anyone got CUES in any availability for CUES today, and you can put it in the WhatsApp group. When I did some practice visits in the West Midlands locally with the ICB, we went into some practices and they were saying, one of the practice owner was saying, we have 3 practices down the road who we work together quite well with on a WhatsApp group. And when I was on holiday for 2 weeks, I checked with the other practices and they said that they could take on those CUES appointments. So I told my receptionist to say, actually, if anyone has CUES, to call these other practices and vice versa. And it worked out really well that they could like support each other for this, because the most important thing is that patient gets seen in a timely manner and is managed appropriately. So just to mix it up just before we finish, just to keep you awake at the moment, we're just going to do some case studies. So just some polls, and they're all anonymous. So do please participate. Mr. Smith calls your practice and says he's been experiencing flashes and floaters since last night. You complete a triage and he said that this patient needs a dilated examination within 24 hours. However, Mr. Smith is only able to get to your practice by car and there's no one who could take him back home. What would you do in this case? So there will be a poll that pops up with 4 options. Please do answer the poll. It is anonymous. It's just there just to make it a bit more interactive and fun. Okay, I'm just going to leave it up for another 10 more seconds. Okay, so this is unanimous, but we've had everyone say that actually advise patient to consider public transport or taxi to the appointment. That's very good. Well done to everyone there. And the most important thing here is to advise the patient about the urgency of the appointment and the timeframes, and to say actually, yes, he needs to come in and he needs to consider alternative transport arrangements. So number 2, Anna calls your practice complaining of a sore watery eye that started 3 days ago, and she's a full-time contact lens wearer. She normally gets her contact lenses from a different practice down the road, but has contacted you for CUES. Is Anna eligible for a CUES assessment? Yes, no, or not sure? Just a few more seconds. Okay, well done. So we've had the majority of people saying no, and no is correct because Anna's symptoms seem like they're related to the anterior eye and likely related to contact lens wear. Therefore, Anna should be redirected to her usual contact lens practice for a contact lens check. However, if she cannot access that contact lens practice, then she can come and see you for cues, provided that you put in the relevant notes. Back to Mr. Smith now. If he was presenting with flashes and floaters, but he was a contact lens wearer, would he be eligible for cues? There's no yes, I'm not sure. Okay, excellent. You're all paying attention. So everyone said, yes, these symptoms are unrelated to contact lens wear. So it seems like this is linked to the posterior eye. Therefore, he would be suitable. Okay, so just a few summary slides. So first of all, check the eligibility of the patient for cues, and you can do that by adding them onto Opera. Then you would triage and screen the patient's symptoms about the time frames and ask all the other relevant questions. And you can check with the clinician, and if eligible, book the patient in a timely manner. If you don't have capacity, then we need to call around other practices to get the patient seen. One final poll, just to make this is especially for the front of house staff here. Which one of these, they all look quite serious, don't they? But which one of these do you think is actually the true ocular emergency out of all those presentations? Could it be A, B, C, or D? Just a bit of fun at the end. Okay, great. So we've had the majority of people saying C, but we do have quite a split. Excuse me. We do have quite a split between A and B as well, but actually it's a corneal ulcer and those. So subconjunctival hemorrhage, conjunctivitis, chalazion, they are all do have symptoms, but the corneal ulcer is the one that actually can be quite sight-threatening. Okay, so well done for everyone for participating. So just to close now, as promised earlier, we do have the clinical lead details. I'll put them up on the screen now. So these are for the North and the Midlands clinical leads. I'll just leave them up for a second. And then we've got the South and the East ones. And again, if you're still not sure, please do contact us centrally at hello@referral.support or click the blue speech bubble in the bottom right-hand corner of Opera and it will take us to the central inbox. And then we will then pass you on to the relevant clinical lead. Okay, thank you very much for your time, everyone. We will open this up to Q&A right now. So there is a Q&A box on your Zoom. So please click that if you have any questions. And we do have the clinical webinars for Qs on the 1st of December as well for practitioners.